So, good evening, everybody, and welcome to today's episode of Marvelous Medicine, where we have planned a panel discussion on what I didn't learn from medical school. The idea started by, chancing upon a Facebook reel which Ravi Shankar shared, where they had shot, one-liners from different doctors in the United States, I think, who were asked, "What did med school not teach you?" So, in our collective wisdom, we realized what med school did not teach you is not the right way to go about it. What we didn't learn from med school is the right way. So that's how we tweaked it. And that's how the title came to be. And because it was Ravi Shankar's brainchild, I quickly roped him in to be the moderator for this panel discussion. Dr. Ravi Shankar is, well known to Marvelous Medicine audience, but a quick introduction to those who haven't been on Marvelous Medicine before is that he's my batchmate from MBBS. We did our MBBS together in JIPMA. After that, he went on to PGI Chandigarh to do his pediatrics and then moved to the US, where so now you can call him a pediatric endocrinologist, and he works for Merck & Co in clinical research. So he's gone through this whole gamut of academic medicine and then research and then industry and research as well. So over to you, Ravi.
Thank you, Vidya. So essentially, as Vidya said, these are things that we didn't learn. So there's a twin theme that will emerge through this. That is, one, maybe some of these things should be taught in the curriculum, but there's also the other underlying theme, which is basically that these are things that you will learn throughout life and as a lifelong learner. But again, I don't want any of the trainees to feel daunted about this. As medical students, I want to assure you and reassure you that you will be able to do anything you set your mind to. So please do not feel like this is so overwhelming that I will not be able to learn all these things. Everybody will be able to. We're just going to give you some pointers about what was important in the panelists' lives. We have had a sort of meeting of minds, if you will, where we talked about these topics, and we've come up with a few. So as I'm talking about these topics and asking for comments, I will introduce the person that I will first address the question to, and others will also chime in. So one of the commonest theme that emerged was how to become effective communicators. Now, we've done several Marvelous Medicine sessions on this, so we did not go back to rehashing that. So if you're wondering why we chose some esoteric sounding topics, it's not really esoteric. It was a common theme, but some common themes had already been discussed quite well. So to start with, one of the things that we found many people agreeing on is this very, very difficult skill, which is to learn your own limitations and learn how to deal with them. How do you really come to terms with the fact that as a physician, your job is to cure people, but you will not be able to do that for everybody. And Suren has been the architect of a slogan, which is, it's not cure at any cost, but care at all times. So with that introduction to this topic, I'm going to pass it on. Anjali was very passionate about how she expressed this thing that she learned along the way. So Anjali will be talking to us. And Anjali, in addition to being a surgeon, as well as running her own hospital and a family, she also, I don't know how she finds the time to do this. She's a member of so many professional organizations. I mean, if I just repeat that, it'll take me a full 5 minutes to just read out all that she's done. But with that wealth of experience, Anjali, over to you.
Thank you, Dr. Ravi Shankar, sir. And thank you all the Marvelous Medicine faculties. It's a wonderful experience altogether to come across, to have such a people across the globe who are sharing their experiences, how they have been brought all together. So as Dr. Ravi Shankar has asked me, that being a surgeon and being a entrepreneur of the hospital and work-life balance, what you are trying to ask me, isn't it, sir?
No, how do you deal with limitations? How do you, deal with unsuccessful outcomes? How do you communicate that better to patients? All that kind of stuff.
Okay, okay. Now, as you will ask me the limitations, that is one aspect. Over the period when you are a practitioner in the first 5 to 10 years, really it's a very difficult challenge to accept, sir, that these are my limitations and I could not give a justice 100% for this surgery and this patient. That is really a difficult task. I remember in the first 10 years in the trauma patients, I used to do a splenectomy without even booking a bag of blood. You used to do a lot of polytrauma patients with multiple risk-taking attitude. But over the period, as you grow on and become a senior consultant, you will realize that one thing is every patient has a right to ask whether I am okay 100% at your given setup. Are you going to give me a safe outcome in a given setup? Third thing, do you advocate that you are the best possible doctor in this city so that you can give me a best outcome? And then fourth thing is, if I can afford the highest possible affordability in the medicine, whether suppose for example a patient has a hepatic tumor, although I am not the proper person to treat that patient, do you have the gut feeling to express your honest feeling that this is not my cup of tea, you better go to this and this setup? So these all things step by step in over the 25 practice, sir, you go on learning, unlearning, relearning, and accept the limitations is really a challenging task. But definitely I will tell you, sir, when you become a part of too many doctor gadgets, too many associations, too many responsibilities are given to your shoulder, and you really will be able to define at much younger age your limitations and what the best you can do, sir.
Thank you. I'm going to switch very quickly and ask Venkat, who is also very passionate about this aspect of something that he's learned over the course of his career. Now, Venkat has trained in India and in the United Kingdom, and he works for the NHS. He's an ophthalmologist who is very passionate about patient care and really believes that finances should not be negotiated with the patient. It should be, so that's why he thrives in a socialized medical setting as the NHS. So Venkat, what is your experience on how to come to terms with the fact that you cannot cure everybody?
Yeah, it's just that the fact that the patient expectations are always high when they come to us with a problem. But as a doctor, you have seen more than the patients. And so I always say, whatever it may be, communication is the most important thing. We may know so many things, the patient may not know so many things, but proper communication with the patient and bringing the patient to your level of understanding of what actually the situation is the most important thing. And not just the patient, even involve the family as well. And yes, there are conditions in ophthalmology, unfortunately, we can't treat at present, like retinitis pigmentosa, or any of these like inherited disorders. There's lots of research going on. But when the patients come to us, they do ask us these questions. The best thing what we can do to them is put them in the correct perspective and what it is about. And also there are support organizations where they can actually contact them and seek help and also meet people with similar condition. And also there are things where we can rehabilitate them in a proper way and still they can continue a proper life. Like even though they can't see, still I always say that except for flying planes, you can do everything else. So you're not different from anybody else. So it's just these things you have to really make the patient at the same time. You can't let them down saying that you don't have, I'm sorry, I don't have anything for you. So you have to make sure that the patient goes you have to make them understand that you have a condition. Unfortunately, there's no treatment. But at the same time, don't get disheartened. You can still do many things in your life. So these are the things which I always face when I come across with patients with especially degenerative conditions.
Thanks, Venkat. So I'm going to switch gears just a little bit and ask Santosh. Santosh is a young professional who has trained in China, has moved to Nepal, is doing both clinical medicine and research, and is also starting to become a member of professional organizations. So, he's starting out. I mean, obviously, he's heading the way Anjali is in terms of his professional organization and responsibilities. So, good luck with that. But I'd like to get your sort of ideas on how you're learning about this thing. You're a pediatrician. How does accepting limitations work with you?
Thank you, sir. Thank you, sir. I'm very young in this sector. I'm audible, yeah?
Yes.
Yeah, thank you. Currently, I'm working as a pediatrician from last 6 years, but I started my medicine 15 years back. And I got my degree from China. And the thing is that I got a scholarship from Nepal and went there. That the concept, the problem, the most important thing is that being a Nepali and learning in a Nepali language, I went to China, which is which is a toxic language in some of words. We don't know anything. That thing, I went there and I learned the language and I came out. So what my experience is that now I'm getting, what I learned in that thing and what I am practicing in Nepal is quite different. It's very vast. They were more advanced because I was using the EMR in China. Right now, I'm working as a pediatrician in Nepal for the last 15 years. I'm not using EMR. So I'm so lagging. I learned so much, I'm not using. Second thing is that there are so many topics that I learned in China and that is not reliable in Nepal. So the means any syllabus or anything or any topics that should be proportionate actually. What is there in a country should be learned actually. I learned over there. I am here not using that. It means it's a quite some of the time I think tedious. I learned so much. I invested so much of time in those things, and I can't use these things. So these are some limitations for me right now that I'm not using. But that is also a plus point for in terms of something that now I'm using in Nepal. I am actually working in Nepal Pediatric Society. It means I'm a executive member, and I've started a Nepal's app actually. We have developed a Nepal's app where we have given the guidelines, using the drug doses and everything that I learned over there is now I'm using in Nepal. And it has given some good way for the new pediatricians, new medical officers working in remote part of Nepal that they can use that app. Some of the things that I did like this. So basically, the curriculums and everything that we learned should be proportionate to the soil. Actually, that is my experience, sir.
Thank you. So moving on to the person who's still in training, I'm going to call on Gayatri. So Gayatri Balachandran is in training as a transplant surgeon. She's a hepatobiliary surgeon, and she juggles her training with all her other responsibilities. So we'd like to understand, like, as somebody who's just starting out on this journey, how do you think limitations will shape you? How do you think you're going to sort of identify them or b deal with them?
Hi, good evening, everyone. First of all, thanks for this opportunity to be here. As everyone has said, I'm probably like the youngest one here, but I think I'd like to bring some perspective as Dr. Ravi has said, I'm still in the process. So how I approached this topic was twofold. What I wish I learned in medical school that wasn't taught, and what I have learned through experience, which once I left medical school. So even though these may sound similar, I think they are quite distinct. The former is something that may be a deficiency of the curriculum, which could be addressed. But the latter are ideas and notions that I acquired on the job, which medical school cannot prepare you for. I think medical school can give you the tools and the materials and get you as far without actually being a doctor. If you get what I mean. I mean, it's like it gives you the training wheels, but at some point the wheels have to come off. And that point, you can't reach that point while in school. So just to illustrate some things that I felt right from internship through my surgical residency and super specialty training, I think one of the most difficult things which I really felt unprepared for, let's say that, was dealing with death. I mean, hands-on. I still remember the first patient in my medical internship that I had to declare as expired. I didn't know actually from, how exactly legally to go about it, what to check, what to document, to actually explaining it to, grief-stricken family, to, what do I say, to give them the bad news. I wasn't prepared for it. There was no dialogue that was taught. This is how you should do it, or this is the way it should be done. And I found myself getting very emotional at that time because, I was just out of MBBS and I didn't know the right words. And I'm not sure if I did it in the most professional way. Oh, with time, I've learned how to do it better. But I still remember that first experience. The first DNR consent I had to take from a family, I choked up because I didn't know how exactly to do it. So these kind of, dealing with bad news. Yeah, you've seen some videos during medical school of a good way to do it and a bad way to do it. But in a real world experience, maybe a doctor might not be the best person to do it. Someone who's trained in psychology, how exactly, what words you should use, what you shouldn't use. I think those are things that I really wish I knew better before I started actually dealing with patients. Patient communication, Dr. Venkat has spoken about it, so I'm not going to speak too much about it. But one more thing that I really had a lot of difficulty accepting were the financial realities of care in this country, where patients were sent away because they didn't have money, and they were said you have to go elsewhere. And again, it was a very difficult thing. You're taught that, this is the thing that has to be done. This patient needs surgery, you counsel for that, but you're not taught to counsel them that it'll cost so much money, and if you don't have money, then you need to go elsewhere. That's a very difficult conversation to have. One word I never heard during medical school was dharma. I'm not sure if many people know what that means. That's discharge against medical advice. And usually that was when patients were advised some treatment, but they couldn't afford it, or they couldn't continue the treatment, so they had to be discharged from hospital. So these kind of situations you never learn about in medical school. So that was difficult for me to get used to. And I wish there were some ways in which that could have been conveyed, or maybe prepared, people could have been, they could have taught us a little bit more, or shared their experiences, and this is how it's going to be. No one tells you these ground realities in life.
That's true. Thank you. And Gayatri, your points have resonated with some of the people in the audience. I saw some comments pop up saying that these were the exact points that they were thinking about. So that's really good. So this is a very common theme. So obviously, if there are trainees in the audience, please work on figuring out how to acquire these skills. These are very important. Now, of course, it depends on what you're doing. If you're planning to do pathology, this is completely irrelevant to you. So, obviously put it into context and figure that out. Moving on, like I said, each of these topics we can talk about the whole hour. So unfortunately, I'll have to be the bad guy here and move on to other things, which is basically how the other thing that many people learn on the job is how to be a part of a team, because we are all part of a team. No physician works in isolation. It's a team. There's a very important excuse me, requirement that you be part of a team. Now, that also means that as the physician, you are the leader of the team. So you need to know how to lead effectively, how to resolve conflicts, and how to behave appropriately with colleagues, etc. So I'm going to start out with my friend, classmate, Veturi Prabhakar Murthy. He is a pediatrician who trained in JIPMER, as he told us just now that he has spent 14 years in JIPMER before he moved out. But so a lot of his experiences are colored with his time in JIPMER. but regardless, he's learned a lot. He runs his own practice and runs a lab with his wife as well. So he runs a group practice. So how do you learn all these things? Because there are different personalities. It's that, to me, that was the most daunting aspect of working as a physician.
Yeah, so as I was saying, that obviously just fresh out of MBBS, I don't think we really know. We are all just individual workers who just bunch together, and just friendships or other relationships help us understand each other and somehow try to get into a team. But as you progress through the post-graduation, and as you get more senior, you actually need to get your juniors to form a team in order to deliver better care. It's very simple. It's a need. And that, I think, if anybody has crossed MBBS and gotten into post-graduation, it's very obvious that in clinical subjects, at least, there is no way we have no option but to form a team. And how do you deal with different kinds of personality? It also depends on what sort of personality you are and whom you're dealing with. And personally, I can frankly tell you, right from that time till even now, I have a big problem trying to deal with people who are upfront or disobey or difficult personalities. Which is, I really don't know how to handle them even till today with all that experience. But that's me. There are other people who handle it much better. So many times, like even in my clinic right now, if there is a situation, I usually ask my wife to handle that kind of things. But as you become
That's one mechanism of coping.
She's just a great. So I'm sharing the responsibility with that. She's great at that. And if I try to do it, it becomes a kind of break. There's nothing more you can do with it. It's not something that's corrective in that aspect. And as since I went into senior residency, as I became the leader of the team on duty, because we had consultants but on a duty, yes, it was important that I identified the plus points of various juniors and then made sure that we allot the right kind of jobs to the right kind of person. It's an experience. I don't think I really read anything about it or was taught anything about it. It's just observation of how our role models, seniors handled their juniors, and we learned over that. We made mistakes, but we learned. The next step when I needed to be in a team was when I was working in a hospital. And gradually there also I got up into the hierarchy and became operations head. They called me medical superintendent. It's a private hospital. They can call you anything there. That's not a problem. It doesn't mean anything. But yeah, I was given a lot of responsibility, no powers. So I had to manage within the responsibility with financial constraints because it's meant to be a charitable hospital. So how to get people to work under constraints is something that I had to learn on the job. Again, not much of formal training was ever accorded to us in any of the teaching curriculum that we faced. It's something that we needed to learn on the job. And as I said today, being the owner of my own practice, it's a lot easier because you are the start and the end point of all the decisions. And even here, I have to admit that difficult employees, people who tend to be combative and questioning, I still have problem handling. But most of the time, I'm able to handle that with just being myself. Anything else? I think I can ask other people to join in.
We're seeing someone's whiteboard. Do we know who it is? Oh, thank you. Thank you. So apologies for that. Sorry, that didn't mean to cut you off. But yeah, I think that's very, very sort of relevant that you realize your limitations about not being able to handle certain things, delegate responsibility, etc. So from your point of view, I'm going to shift slightly and ask Suren. Now, Suren, again, another classmate, has had this unique opportunity of practicing different forms of medicine, from emergency medicine to family practice to a whole bunch of different aspects of medicine on 3 separate continents. So with that perspective, Suren, can you tell us what you learned about being part of a team and how that worked out?
Yeah, like listening to most of the speakers and looking at the notes, I think there's an overlap and everybody has similar kind of ideas. And I think to help the curriculum and the junior doctors and the next generation of doctors to come through, I think, as I said before, it's not to cure, but as a team, we can, share ideas and to care and give the patient the optimal quality of life. And we need to observe, listen, respect, and learn to deal with conflict resolution skills. And, there comes to the old adage, like the Shakespearean thing, to be or not to be. So in GP practice, you tend to learn these acronyms and you say to do or not to do. Teaching the skill of deciding, what to do in the face of uncertainty. That comes up, and if to some problems we can attach a formal diagnosis, that's a bonus. But what we must always do for every problem, diagnosed or not, is decide what to do about it. And as GPs, we sort of redefining sometimes our professional roles, and we are generally, referred to as the jack of all trades. And traditionally, that's what it is, and we are sort of become skilled at managing teams, and we got to resolve conflicts and learn to communicate better.
Thanks, Suren. Communication again. I think people will realize that that's the theme, that's the overarching theme. Everything requires communication. And the next topic that I'm going to switch over, and I'm going to actually put Shyam in the hot seat. Shyam is from JIPMA. He did his medicine from JIPMA, but he's also trained in clinical medicine in the US, and most importantly, has a PhD in computer sciences. He now works in research, in a different form of research that many of us are used to. So I'm going to put him on the spot slightly and ask him about another theme that came out, which is actually very dear to my heart, which is basically, how do we get physicians to understand and realize that they deserve to be paid appropriately? There is no shame or no need to feel, in any way uneasy about asking for what your skills, what should be paid for your skills. So this is, the monetizing of business. It's not a dirty word. I mean, we all need to make a living, and we all provide a service. We should be able to be compensated for that. So Shyam, I'm putting you on the spot and want to know how you dealt with this thing through your career, about how did you negotiate benefits, contracts, pay, etc., and what did you learn along the way?
Sure. Yeah, that's a great question. And, most of the time that we spend in medical training, especially if you're in a big academic center like JIPMA is, for example, you don't really think much about how you even get paid and how people are valued. And that goes on almost through the entirety of your training. So even in the US, when you're training as a resident or a fellow, the salaries are all kind of fixed. So you don't really have to negotiate anything. And you know that everyone is getting paid the same. Now, once you get out of all this training and then you're looking for a job, either in a practice or in an academic center or in the corporate sector, one of the very interesting things about the US is that it's opaque. You really don't know what your peers are making necessarily. And now this comes as a surprise first. And then you have to figure out how to actually navigate the system, because once you're in, you slowly start to find out
what your peers are making. And then you're kind of stuck. You can't really negotiate once you've already accepted your position. And this is true both for clinical medicine and even for research, or even like a faculty members. So you'll actually be quite surprised to know that faculty member in universities like me, like tenured people, we have to negotiate our salaries. Otherwise, you're going to be stuck with a pretty low salary. There is no one sort of looking after your back. Your boss, like the chair of the department or the dean of the medical school, is not your friend when it comes to compensation at all. They're trying to get as much work as they can out of you than to the amount of money that they're paying. Now, in the corporate sector, you learn this really quickly, especially if you're in engineering or software like my wife is in, because they move jobs every few years. But generally in the clinical field, sometimes we don't really move that fast. And so we don't really negotiate. So when I entered my first real job, and I actually entered my first real job when I was close to 40, as a faculty member with both clinical responsibilities and research responsibilities at the University of Pittsburgh, I actually didn't negotiate. And in fact, I was very surprised when my research mentor came and told me after that, he said, "You asked for too little." And he actually upped my salary. And after that, as I went through the promotions, I would basically ask my boss, okay, what is it that you usually pay when you get promoted? And, they'll come back with answers like 10 and 15%. Until my wife told me, like, that's what they'll always tell you. But it's up to you to actually figure out what you want. And in my latest promotion, she just told me, just ask for double what you're making. And guess what? I asked double of what I'm making, and I was given it. And she told me, like, you asked too little. So the whole art of negotiation in the US is you have to ask something which you think makes no sense at all. And you think that you're insulting your boss. But it's really a negotiation game. So you ask for something really astronomical, and then you'll probably go down somewhat based on what your boss is willing to give you. And what is very interesting is that what you end up getting paid sometimes is very unconnected with your skill set. So similar surgeons might make very different salaries. It all depends upon why they need you and when they need you and how desperate they need you at that point in time. So when I got recently promoted, they desperately need me in that place. And so they were willing to give me anything. And looks like I probably didn't ask that much based on the fact that they just gave it to me the moment I asked. Usually the way you want it to happen is that they negotiate with you and they ask you to come down. If they don't ask you to come down and they just say yes to you, you haven't asked enough, or you're leaving money on the table. So this is something you have to learn, and it's worth sort of practicing this with somebody before you actually go over to your boss or your dean when you're doing the actual negotiations. But it's an important skill, because once you're inside an organization and you start to realize what other people are making, and if you're making less, it just solves the whole experience in that organization. And one of the biggest things you start to notice is the amount of inequity that goes on. Women make easily 20% less for the same job just because they don't negotiate. People from the East, where we are not used to negotiating, where you sort of trust your boss to give you the right amount, tend to make less because they haven't asked for more. But I think even in India now that is starting to happen, that you really have to negotiate and you have to ask. And also when you ask for things or ask for compensation or for resources, you want to lay out as to why you want that. So you want to also make a case that you're actually worth it, not just for something which you don't think they can actually afford. So you definitely want to have a basis for what you're asking for and negotiating for what you're asking for. but definitely you want to ask a lot more than what often we think we are worth it. And it's also worth probably talking to your peers in other places to get an idea, to get some advice to how you go about doing. I mean, sometimes it's not just your pay. Sometimes an organization may not be able to give you sufficient pay that you're asking for, but they're willing to give you other things like maybe the amount of vacation, or maybe free trips to conferences and so on and so forth. So you can negotiate across sort of many axes. Yeah,
or half off tuition for your kids, right? So,
yeah, I mean, that is one of the things I negotiated. My kid gets free tuition.
Yeah, and so two things that I wanted to add to what Sham's talking about before I call on somebody else. One is that you have to ask, so that's one part. But before you ask, two things. You don't have to feel ashamed about it. So when Sham talked about people from the East don't ask, one of the reasons why we don't ask is that we are taught as physicians or as people trained in medicine that asking for money is somehow infra dig. It's not in any way. I think there was a comment that said dark side. So it's really not dark. This has to be brought into the light. You need to know how to evaluate your own worth and how to ask for it. And the second part that I wanted to say is there's no harm in asking, because the worst thing they can do is say no, right? So, and we've heard no so many times in multiple different ways, even from our toddlers. So, that's something that we should be used to. So we really shouldn't be bothered about a no, but at the same time, we should not be bothered about asking. Somehow that seems to be tainted. And I really want all the trainees to understand that there is no need to feel tainted about it. It is a service, and you bring value, and you need to be compensated for it. Of course, there's no point in being unreasonable about it, but that's the same thing. So I'm going to ask Venkat. I'm going to put him on the spot, because he's part of the NHS. How do they deal with salaries, compensation, benefits? How does that work there? And what have you learned in that process, Venkat?
There's nothing we can do, in the sense that just now I sent a message on chat. It's all standardized. Like there's banding systems here. So if a consultant is starting, the starting salary is fixed across the whole nation. There's nothing like it varies from one county to another county or anything. National Health Services is standardized. So if after 5 years, I'll get this much salary. After 10 years, I'll get this much salary. It's all standardized. So there's nothing like if somebody's there, like a professor with so many years of experience, it's already set what the salary should be across the whole nation. So there's nothing like bargaining here.
So if you find it very uncomfortable to do those things, then that is a system that you can think of. So it's not one size fits all.
If I can just interrupt you here, since we have had one round with all the audience, KK has made several points on the chat box, and I think he's free and ready. His camera's on, so maybe you can quickly jump to KK before we go back to our panelists.
Thank you, Vidya. So thank you for monitoring that. I wasn't able to. So, KK, you're on mute.
Yes, I know I unmuted myself, but I've essentially expressed what I felt whenever those comments. It's a wonderful discussion, really. And I was particularly thrilled about listening to Gayatri. I think she articulated some very important points that I think haven't been taught to us in medical school, and we've learned the hard way, just as she has learned the hard way. So I think we should have gotten more Gayatris in this session, really, because we would get a contemporary feel. The other issue, Ravi, is that perhaps we are a little disconnected from our generation, the contemporary, the people who are passing out of medical school today. And some of the issues we are articulating based on our own experiences and some presumptions. So that's something I would like to caution you. Most of today's doctors, especially the ones from private medical colleges, don't feel ashamed about asking for a large salary. In fact, they ask for salaries which is embarrassing to me to watch them ask, but that's what happens, and I don't know where the line is to be drawn. There are unique aspects about working in India, in terms of just where we are in India. We are at a very unique situation. There is just so much of inequity in medicine. There are so many families that are having to be served. And when you have to advocate for all of them at the same time, negotiate for a large salary, it becomes very challenging. So that's something which I wanted to tell. Uh, Other than that, I think it's all going so well with this discussion. So there's just so much that I'm learning and thinking about when you are asking questions.
Thanks,
Yeah, I
KK.
request everyone to put their comments on the chat box, and if you think any particular point needs to be raised, please feel free to add it to the chat box. We'll get to you soon. Over to you, Ravi.
Thanks. Thank you. I'm going to around just a little bit to a related aspect, which is the business of medicine. I started talking about it, about money, insurance, billing, and all those things again, which we hesitate a lot about, but is a reality in today's world. I mean, a contractor wouldn't build you a house if you didn't have the money, right? So the same way, there must be some way of dealing with it, of understanding it, and not getting so emotionally involved in it, the business of medicine. And here I'm going to open it up. Any one of the panelists who wants to talk about it can talk about it. Gayatri already talked about how difficult it was and how difficult it still is for her to deal with this aspect of not having money for the appropriate treatment, and how do you handle that? But that is the reality of life. So how is that handled? We have people who run hospitals, group practices, etc. So everybody's view is solicited. So I'm going to open it up.
If I could take this, sir.
Yes.
Yes. Now, regarding the affordability of the patient is one aspect. Second is whatever expenses as a entrepreneur of the hospital and as a treating surgeon is a different aspect, sir. And third thing is, out of the hospital expenditure, what the surgeon is going to gain through it, what is the benefit to the hospital, and what is the pocket of the patient. These are the four aspects you have to look into when you are dealing with such type of catastrophe. Now, if the surgery which you are dealing with is benign in nature, that is not, if at all, what maximum worst can happen in the given scenario, that is one aspect. Second is, whenever you are communicating with the patient regarding the risk assessment of the surgery and the related output of the surgery, if the patient is going to help you in every aspect, whatever better and whatever worst which you are coming through. So these are some of the delicate aspects when you are practicing at a solo practitioner in the hospital. With 2 or 3 practitioners associated with you, but not a full trained hepatologist or a liver transplant surgeon or mega MCH people are not associated with you. So it's a very thin line of balance where if one patient you are going to do a mega surgery and which is not going to be a risk taking, in such situation, even though you are earning less as a pocket in that surgery, you are going to gain much of the name and fame. So these are some of the delicate aspects in medical school which we are not taught about. There we are, when you enter into the medical college or a medical school, we are into the super era that we have done something extraordinary out of the globe and we are here in the medical school like we see in the Bollywood and Hollywood movies. But now when my son is into the medical college in the second year, now he is very smart generation. Why? Because he is looking into a web series which has been associated with how the medical college runs and how the decision making of the doctors, they help in output of the patient. So these generation is very smart that what are their limitations, what is actually the thing to be done in a patient assess, if post-op complication is there, if you are failing into the communication, if patient doesn't give the hospital bill. So I think these such web series are also making them more wiser than that of the medical school also, sir.
Interesting concept. I hadn't thought about that.
So Woody, can we get Shiva here because he has to
sure.
leave in a short while?
Oh, sure, absolutely.
Yeah,
absolutely.
Health economics is your passion, so we'd like to hear from you, Shiva.
Yeah, no. One thing for me was, health economics. First thing first, when I came in and I had to start to practice, and then I started to open a practice, and there was a huge demand for medicine, and eventually I was running 3 practices. I had no idea about practice management. How do you bill? How do you manage staff? How do you employ staff? How to do HR management? And there's a whole lot of regulations in South Africa when you employ people. You have to pay unemployment fund, you have to pay PAYE, you have to pay skills development levy. You have to actually employ a practice manager to manage your practice before you could do the practice. And so that was the first thing that was there, and it really made a big problem for me. But fortunately, there was a book Kavi Pistorius wrote, which was called Practice Management. We read it and we managed to do that on our own. But on a broader perspective, how to organize, and I think that level has not come to in India yet, how to organize practitioners such that they can collectively bargain for the best prices such that you can get the best benefit for your patients. So the second thing that I had to learn very fast, I became a chairperson of IPA. IPA is Independent Practitioners Associations, where all the GPs get together, they form an association. And then this association then tries to get the best benefit and the best quality of service to the community that they serve. Now you found that there are 50 different generics of one particular drug and the different prices for it. How to then make a formulary such that you bargain with the pharmaceutical companies and get the best price for that particular generic drug that you need, such that you can buy that, get economy of scale for that, and get that to your patients. To bargain then with the pathologist to say, we will give you the bulk of the services. Can you give it to us at this price so that it becomes affordable for the patient? So health economics was something that I had to learn on my own, and I became quite good at it to such an extent that when I had to actually go to the government and actually, for my knowledge that I learned on my own, I was invited to the government to manage my whole province as head of department, and I had to use that skill that I learned. And now, for the first time, we are teaching health economics. I'm one of the guest lecturers here and on health economics, and to look at health economics. Now, to a great extent, when people practice there in India, but not like in the UK, where there's an NHS system, there you have to work in a collective, and the NHS does quite a lot of those things for you in the background. But for us here, where we have to organize ourselves, we have to do all these works to ourselves. What Ravi was talking, what they were talking about in NHS, where your salaries are determined and determine what you will get paid. We have to decide that for ourselves and build a service for a community, such that now we have got a situation where in my town, for example, we are contracted as a group of doctors to take care of the whole community, and we get paid a certain amount of money to take care of that community, and it's our responsibility to build a basket of services that we have to provide and be within budget and manage that. So this year you learned how to prevent duplication. At the present moment, you go to India, one doctor does this investigations, you go to another doctor, they repeat all the investigations again. We don't have an electronic record. And this ends up in a lot of wastage. Whereas when you start working collectively, you learn how to manage that better. You learn how to be more economical. And now people ask, how do you guys in Uteneg, where I live, are managing these patients at 25% of what the national average is? This is the amount of savings that you can bring into a system. And health economics actually, you have to be a ruthless negotiator, similar to Donald Trump. I don't want to use him as an example, but you got to be a ruthless negotiator, get economy of scale, but at the same time, there's a big downfall to this. You can underservice patients when you go into that kind of a system. So you have to build quality of care and that to take place. And then when you take this on the national level, I had to go and read Park all over again, because when we went to do government policy and make government plans and draw up government protocols, you have to look at community medicine, and there the only source of information now is WHO. And WHO is not specific to your country. Then you have to do a lot of research, and you find there's not much research. There's a lot of research in clinical medicine, but there's not much research in community medicine, where you have to manage your community. For example, if you've got scabies, it doesn't matter how clinically you manage a patient, but if you don't get water and soap and things to the community and teach them about washing, you'll never get rid of the scabies. The same way, about immunization and things like that. So health economics, looking at a global picture, and then how to take care of a community at large. That was something we had to learn on our own. Thanks, Vidya, for this. It's nice also to see all my friends there. They're looking very good.
Nice to see you too, Shiva. So Shiva brought up, actually integrated a lot of points that the panelists had made themselves. And one of them that Sham had brought up was that some of us have to go into policy making. And Shiva very beautifully explained how that works and what you need. So for people who are planning to do policy related stuff, Park is a very good Bible to use. Sorry, my screen has gone completely blank. Have I done something really crazy, or can you guys see me? Hear me?
Yeah, we can see you.
Okay, sorry. Okay, it came right back, so it must have been something with the internet. Sorry about that. This whole thing about the economics of healthcare, again, is one of those things that we really need to learn more about. And maybe the newer generation is doing better. I had not thought about TV series and using that to get educated on life skills in medicine. But that's an interesting concept. And maybe, there'll be more that could be done on that aspect as well. From moving from all these things to something that is very close to home, it's very important, and it sort of builds up everything in terms of how do we care for ourselves, because what medicine and the practice of medicine is not a sprint, it's a marathon. So how do you maintain yourself for a very long and productive professional life? Like, how do you maintain work-life balance, how to recognize burnout, how to prevent burnout. So again, I'm going to start with Suren, with experience across so many different continents. Suren, what have you learned about this aspect of our professional and personal lives, where they intersect?
Like having returned from India to South Africa, it was a different kind of experience. We had to write exams again. We were sent out into a rural area and worked long hours. And thereafter, we got back and I worked as a surgical registrar. And then again, you sort of doing long hours. And due to financial constraints and personal reasons, I went and did locums as a GP for financial reasons, because you weren't getting paid much in the hospital. And my post as a surgical registrar was held back for me for a year, but then I got stuck into GP practice, and we had extended family, and you had family support as well. And hired labor is cheap, so you could use that. And then I myself became quite successful as a general practitioner, and I had 3 very big, large practices, and we were also accredited by the local council. And I had to sort of use times to suit my boys, which were growing. And being in your own practice, you were your own boss. And you could do things like that. So if I knew my sons had soccer practice, I would arrange to be there for them, and I'd have a locum to take care of the practice. So I did all those kind of things. But then again, over the period of time, you'd find that you'd work long hours. And by the end of the day, you'd start off in the morning at 7. You'd only get home at 8. And I also had a home practice. And then suddenly when I get home, I'll have 5 or 6 cars waiting in my driveway. And, that's how the community was. and you'd go home and your patients were sort of mindful of the fact that you're getting home. They'd tell you, oh, we had a cup of tea, you have your dinner and we'll wait for you, you know. And so it is a different kind of feel. And your patients became your friends. You sort of were respected in the community. But things now are different because patients are very much knowledgeable about disease and pathology. So they question you, and you got Dr. Google on the one hand. And when patients come in GP practice, they come in very scripted. They come in with a whole lot of questions. And for example, they'll come in and they'll tell you, I've got this headache, intractable, I've got an aura, I've got a migraine. And all the guy needs is a medical certificate. So sometimes these things can drain on you because you might have a room full of patients and you can see that you need to spend time with some sick patient, but there's a guy here who's wanting a medical certificate. But this is the challenges of uh, GP practice, and that's where the art of communication comes in, and the time management, and as Siva said, health economics. You learn things on the job, and you sort of tailor things to suit your needs as time goes on. Yeah.
Right.
And
So that,
yeah,
sorry,
go on.
didn't mean to interrupt. Go ahead. Sorry.
And you sort of learn that sometimes that the long hours can take a toll on your family and your personal relationships, and then you need to sort of work out a formula for yourself to say, okay, this is what I'm going to do. And I used to take one day off a week to do what I needed to do, spend time to myself, take care of myself, self-care. And we as doctors, we are smart people, but I think we are poor business people, and we give all the advice in the world, but we generally don't take it ourselves. And I think that's where the self-care element comes into being, and the life care and work balance is imperative and important. Yeah.
So,
Thanks,
Ilango said he has to leave at 9. So, if you can just squeeze him in,
sure.
he's been here from
Yes.
the beginning. Ilango, are you still there?
Yeah,
Yes.
I am there.
And
I'm in the car, so I have not switched on the camera.
Yeah.
That's fine. No, Ilango, I just want to tell you before you get started, I hope you've made notes because for part 2, you're going to be dealing with it.
I was in the car, but I think the discussion was fantastic. You see, when you talk with a large group of people, you realize there is actually so much to learn. Okay, coming to the point, actually, what I felt was we discussed about what we did not learn in medical school. I think my wife was sharing the idea that we were not taught how to write systems that are much more that can create impact rather than individual things. So system learning was not there. For my sake, from my side, what I felt was I took everything that my teachers taught as facts. Everything. If they say something, it's like God. It's like the final word for me. So I realized over time it was not so. The facts all evolve, and things change, and things which are true can completely become wrong the next time, and new science is evolving. It took a lot of time for me to understand that. But the other things like caring for the patient is more important. I think that philosophy was taught to me by both my teachers and because I was a second generation doctor, I could learn it from watching my father. And the books that Professor Nandi wrote, which was gifted to me, was a wonderful thing for me. So the biggest difficulty I had was unlearning and relearning things. And now in the current practice, in transplant or as a GI surgeon, I find that each time I have to learn and unlearn things. And that is probably the key thing which I had to, which I was never taught in medical school, or I never learned in medical school. The third point which I wanted to highlight was what I made a mistake was I never consolidated my learning in the early days. The notebooks which I share now in learning general surgery were the result of they all happened in the later years of my learning. But the earlier years, I wish I had really consolidated my work, properly written down things so that I could have learned much more better. So for those who would benefit out of it, these are the things that I really missed doing. I think my medical school did not teach that, but I think some other medical schools might have really taught that. Thank you.
Thanks, Ilango. I don't think we all learned that, even if it was taught. So it's a skill that we had to learn over time. But I like your point about trust but verify. So you trust what is taught to you, but make sure that you verify and make sure that it is correct before you incorporate it into something bigger. I was going to ask, both Gayatri and Dr. Adhikari to tell us, Santosh to tell us what they do for self-care as the younger generation in this. I think many of us, the older generation, we really did not understand the importance of time management or self-care or work-life balance. These were sort of four-letter words in our vocabulary when we were training. And even in our early years of practice. But in the newer generation, how are you handling all these things?
Thank you, sir. Okay, the first thing is that life and time, the both are important actually, and we'll get only once in our life. So to preserve it, the main thing right now, because the mental health and everything is coming to our. And the second thing that I learned from one of our professor, that there was some mishappening and he has to be penalized. And he was saying with that, I worked for a lot of years, 30 or 40 years, and I can pay this sort of money. But you are now becoming a junior doctor and you have to work so long time to get that money. And if there are some circumstances, then you will be quitting your job actually. You were saying like that me 15 years back. That really tossed me. So from that time, what my position is that whenever I used to treat patient, the main basic thing is do no harm that I am doing right now. The second part is the communication part that we'll explain it more easily. And third is that in my opinion, I have limited limitations actually. I don't desire so much of things. That makes me to help my limitation quite less thing. I don't dream of Audi car and I don't dream of Ferrari. If I'm dreaming for that, then I have to work for that and I have to be stressed more. And I think money should be going back to others, not we should be moving behind money. Not a lot actually in these few years. And as a practitioner, it's a genuine job that we have to deal with patient, deal with disease, and deal with the patients in financial hardship actually. That is the main thing. That our patients are in hardship. And that too is more in my country actually. The people from my place, they're not in the high economic status. So I have to treat them at all because they will be, I'm working in a government hospital. So many people, they will be coming there, means they will be either out of pocket, there is no any money, or they have already expended all the money they're in a private hospital and they will come back to my hospital. That time they don't have any single penny also. That time we have to treat that things. So that's a challenging thing for us. And for myself, I expect only less things, don't expect more things. And I think that to live and to pass away this world with some good deeds is the main thing for me, actually. That is the only thing for me. So I don't stress so much. And right now I'm doing my part-time business actually, because this medicine field will not give me so much of money that I desire. But if I do some part of means should be entrepreneurship and something else that can sustain my life and my family. That is what I'm doing right now. It's from last 5 years I'm doing that thing. So that is my thing, how I manage.
Interesting. So Gayatri, what are your techniques for coping? I know you have a lot of responsibilities in addition to training.
So I also during training, I trained during my surgery and super specialty training. There was an overwhelming, it was an old industry working model of focus on effort. I remember one of my chiefs when I joined surgery said, for the next 3 years, food and sleep are not important. We were taught to glorify work and prioritize health and everything else, and well-being second. So come in early, leave late, work week. That was the way to be. That was the mark of a dedicated surgeon. But I learned quite late that there's a fine line between dedication and overwork. Because when you're in a system that lacks flexibility, overwork can quickly degenerate into, dangerous, self-destructive, as well as a dangerous environment for your patients. And I learned that very late. So what I have learned is it's not selfish to take care of yourself. Prioritizing your needs does not make you selfish. I always had the other way around, that if I focus on myself last, everything else should be first. But actually you can't pour from an empty cup. In air when you go on planes, the safety instructions, they always say put the oxygen mask on for yourself before you help others, because unless you are in a position to take care of yourself in every sense of the word, physical, mental, emotional, then there's no way you can care for your patients or for your family. And I'm still learning that. So I think the most important thing I've learned is to say no when I have to. Other things that I do to, balance things is schedule. I'm a fanatic planner. I plan meal plans for the whole week. I try to plan work schedules and things around work and everything. That's how I maintain some semblance of balance. So having a schedule or a to-do list helps me identify things that are priority, must do, can be done, don't need to be done. I think that helps things. Letting go of ego, knowing that there are things that I cannot do and I need to ask help for. Then important things is focusing on healthy eating, exercise. I try to jog every day. Some personal downtime, some time away from work, hobbies, art, dance, music. I think those are the things that, again, you're not taught during medical school, that you have to have a life outside of work. It is okay and you have to have it. That is something that I'm not saying you shouldn't be dedicated to work, but you can't be dedicated if you don't preserve some semblance of yourself. That's something that I think it's important. Limiting distractions, screen free time, time out for yourself. All those things are things that I have learned help me balance things and, keep away the, burnout, because you don't want to go to that stage where you can't manage the stress. So these small things are ways that I have found help.
Again, very beautifully said, Gayatri. Thank you so much. And I hope all the younger trainees have been listening. So having hobbies, doing things for yourself is not bad. It's actually absolutely necessary. And so it is important. And like Gayatri said, you cannot pour from an empty cup. So if you're not taking care of yourself, you really probably are not taking care of other people very well either. So that's a concept that's sort of alien to people from my generation. So really, that's a concept that really everybody needs to understand, take to heart, and go from there. Going back to, so this is from my personal perspective, I found the difference between, say, clinical practice, academic research, and complete total research is that with each of these, my work-life balance improved. So I'm going to ask Shyam if he finds it the same way. It's not like we do less work in research, but it's less time constraint. I don't have a patient waiting for me on a gurney to do something. So I have time to do something else and then come back to this. A spreadsheet can always wait, or a document can always wait. So that's the thing that I have learned. But Shyam, what do you think?
Yeah. So yeah, I can probably contrast a clinical specialty, which is very, say, shift oriented, with something like research where there are no boundaries at all. So for example, in anesthesiology, the lines are very clearly laid out, that you're only so many hours at work, and after that you have to have a break. So that's very similar to like what airline pilots need to do, because they're doing some really critical on-the-job decision making. And on the research side, there are no boundaries at all. In fact, you're doing, in the research world, meetings are things where you don't actually do work, and they fill your entire day. Your actual work actually starts in the evening. Now, that's when you're doing your writing, that's when you're thinking about stuff. And your weekends are the days where you actually can get a lot of stuff done. And this only works for a few years. And then you start to burn out because you can't really work 7 days a week and keep going at it, even though it seems like, you're not physically that active. You can take your breaks, you can have your own schedule, so on and so forth, compared to something like, say, anesthesiology, where it's all laid out for you. And in research, it's even harder to diagnose that you're burning out compared to clinical care. In clinical care, if there's a monitoring system which says that you're making mistakes, it's very easy to figure out that you're making more mistakes. And then you can very quickly look at yourself and see whether you're starting to burn out. In the research world, it's very hard to sometimes figure out, whether you're functioning even optimally, because 99% of the things that we try and research fail anyway. So by looking at your failure rate, it's often hard to figure out, whether you're burning out. And what usually happens is, if you have family who are pretty perspective, like, your wife and your kids or your spouse, and they start telling you like, I told you something, and you probably don't even remember what I told you. And then you start to realize that, okay, you just are unable to pay attention to even like regular things in life. And research burnout is very insidious. It's very hard to come back from because the process is very long. It takes years before you burn out. In the clinical world, often rules and regulations, if you're in a big organization or a hospital, they change on a dime. Like COVID starts and suddenly the whole thing changes. And people very quickly start to realize that they're being overworked and they burn out. In the research world, it's far more insidious, and our colleagues are burnt out and they're completely done at this point. Mentally, they're unable to actually think anymore. And in some ways, I don't know, it's a sort of, I get a schizophrenic feel when I used to go back and forth from the clinical world to the research world. In the clinical world, sometimes you can put in long hours, but you don't have to be cognitively that sharp because you can be on autopilot for a lot of things. In the research world, there's no autopilot at all. Everything has to be done with a certain level of cognitive work. And so you can only work so long, and sleep matters a lot if you're doing research. You just can't be sleep deprived. If you're sleep deprived, you actually get nothing done the next day. You might write some words, but it makes no sense when you read after you get back to it. I think burnout, life-work balance is important. And I've noticed this, especially in the research world, that taking time off improves your productivity a lot. So sometimes my time off is when I'm on a flight, a long flight. That's my time off because I got nothing else to do. So I just sleep. And I come back after a flight and suddenly, I found a solution to a problem I was thinking about. And so the downtime matters a lot in coming up with solutions. And also, I think in the clinical world, to a certain extent, it probably makes you more look at what you've done in the past, reflect on what you have done if you have downtime. And having downtime definitely helps you to reflect. A lot of this is probably the brain does this unconsciously. But without having sufficient breaks, sufficient sleep, you might be putting in a lot of hours, but they're not really productive hours. And at the end of the day, what you really care about is quality. And this is one of the things that worries me about medicine is that, and to a certain extent, the research also what's happening is quantity has taken over quality. And it's the numbers, and research world also that's starting to happen. It's the numbers of papers you produce, even though they might be crap. It's the same thing with the clinical world. The number of patients you see, even though you might be giving suboptimal care. And that is becoming more and more easy to count and easy to reimburse, and people are starting to optimize for it. And that, I think, is a pretty dangerous game. What you really want is do good for a few people and pursue 2 or 3 good ideas and do work done. It's not your job to save the world. It's not your job to save every patient which comes in your way. It's not your job to fix every unknown medical problem. Just do a few things. So that's
I think Sham encapsulated everything beautifully. I saw a thing that KK is wants to say something, right?
Before that, Woody, since we KK specifically mentioned that we should have had more younger people on the panel. We have Adit on the call, who is also an entrepreneur. So Adit, we'd like to hear from you.
Hi, ma'am. Very nice set of panel discussions. I think to add my small 2 cents, since I moved into a more entrepreneurial role, when I try to interact with doctors, I've been trying to hire a lot of junior doctors for my company to work on a content creation role. I feel like medical school has really directs us only towards knowledge gaining and not towards any kind of prospects, career oriented, career building, or right from how to build your resume to how do you present yourself in an interview, how do you structure a career, whichever side it has to be, whether it has to be in the clinical side or whether you want to leverage your experience on the research side and or on the industry side. So I feel like those are aspects which medical school has not focused on either by design or by sheer negligence. But I feel moving forward, doctors are going to have so many more opportunities coming their way. And because of doctors not being ready to go after these roles, a lot of these are going off to members who are maybe from a allied or like supportive health role basis workers. And that is something which if we prepare ourselves early on in med school, we might be able to take advantage of.
Thanks, Adit. That's an interesting concept, because I have the exact opposite feeling that medical school prepared me for anything and everything, that there was nothing that I couldn't do. Like if I could take charge of reviving a patient, performing CPR, leading that team, I can do anything. So that kind of thing was something that I got out of my medical school training, is that, nothing can be as important as doing that, as doing CPR or resuscitating a patient. So everything else fell into perspective, when I started writing my first grant, or when I moved to industry and took over a clinical research position. So it's very, I don't know, I think it's all in perspective.
I agree with you, sir, in the sense that we build the capacity to be able to do all of that. We are put through extremely harsh learning conditions that we come out being capable of handling anything which is thrown at us, but we are not methodologically taught in terms of how to build your practice or all of this. If we already have those skills as well, instead of having to learn on the job, I'm sure we since we go through medical school, everything else after that actually feels like something, anything you give, I can do or I can manage.
Exactly. But and that is exactly what I want all the trainees to know. It's that we are in a unique position, just like you mentioned. You come out being able to do anything, but your point is well made, that you should appreciate it, learn to know how to harness all those capabilities. Correct? Is that what you're saying?
Absolutely. And I think now we are looking at people wanting specialized trained members going into admin. I think the days where senior practitioners gradually transitioning into admin is a little less likely with the newer generation. There are people who are going to come in trained particularly for that and who are going to be building a career with 20 years of admin experience by the time they get to their 40s. So we're going to be competing with them, which means we'll also need that kind of backing, which was probably, I think, something the next generation we will face as we step into more senior roles in the industry.
Thank you,
Taken.
Adit. Ravi, Dr. Bade, one of our teachers, also had something to say. Dr. Bade, if you're still on the call, please unmute yourself.
Hello, are
Yes,
you
sir.
able to hear?
Yes,
Yes,
sir.
sir.
Yeah. See, just few things. One thing about work-life balance, which most of the speakers have emphasized. I just want to say one thing that I think I was able to manage both work-life balance quite well, and I think I was fairly successful in that. So I think it is up to the individual to learn, because once you become an adult, you have to understand what you want. So work-life balance, I think we should be able to achieve. And even till today, till the day I retired, I had both. I could manage quite well. Second thing, I just want to learn to tell that we have to learn that everybody makes mistakes. See, to err is a human, that everybody knows. But then we have to accept that, and we have to see that we accept our own mistakes, plus we accept our peers' mistake. And when we want to take some action on that, we have to learn how to balance it in such a way that it promotes a positive attitude on that individual. That is what not taught to us. But I think over a period of time, we will have to see how to focus on that. And finally, one more thing I wanted to say. Vidya, you just read that last point. Third point I
Yeah,
put.
so I will read that. Just before that, it is just like you were saying, it's very strange that all of us have the same thoughts. So learning from mistakes and how to manage mistakes was one of the points we were supposed to discuss.
Yeah.
The last thing that Dr.
I have
Bade
said,
was that you have to develop patient safety attitude,
yeah.
which
See,
probably
that
we were
is
not taught. Fortunately, it's very much in the
in the present age.
top now, and
Yeah.
emphasis was never given to understand the changes that affect us and our patient. That's another thing that Suren had highlighted, that how we have to make the patients part of this whole. They are partners in treatment. So, Dr. Bade, thank you for your inputs. We are
And
going
one more thing, Vidya, one more very small thing. Like, we have to have a managerial skill. I think I have undergone a senior management executive program late. So if you go into that, some say online course or something like that, which was never emphasized to us during our education. So I learned it actually after retirement. I did a 1-year program in Indian Institute of Management in Nagpur, online and offline, and it helps a lot. So I think our doctors should also try to do that, which was never taught to us. I think that is very important, that we should learn that.
Yes, Dr. Bade, the youngster Adit also had the same thing to say, that we are going to miss out on a lot of like most corporate hospitals are now managed by non-doctors, people who are selling cards or toothpaste are coming as managers in India. That's because we have all not stepped up to the job. So your point
So
is
I think we have to
well
learn
taken.
that now. We have to do that.
Yes, sir. Back to you, Ravi. Sorry for the interruptions.
No. That's perfectly fine. I was actually going to say, if KK is around, maybe he can add his points before he leaves. Sorry, KK. Can someone check if he's already left?
Yeah, he's still there, but he's muted. So
okay.
If you have any questions to the panelists, go ahead. I'll rustle up the others soon.
Okay. No, I was going to say that was Dr. Bade's points were a great segue into the next point that we were going to make, which is basically to, how do we deal with mistakes? So I'm going to skip that. And then I am going to ask the other point that was that resonated very deeply with many people and with me as well, was this concept of how to ask for help and how to destigmatize asking for help. So Venkat was really the most passionate about that, but everybody talked about it. So I'm going to put Venkat on the spot and have Venkat talk about how did you learn about when to ask for help, how to ask for help, and to whom, do you go to?
See, yeah, I mean, say medicine is a teamwork. So you can't do on your own everything. And that's why there are so many other people working with you, like the ancillary staff. So I mean, it's unfair as well to do everything, taking over, you do everything for the patient or your department or whatever it is. Uh, I think distribution of work, that's what actually leads to even burnout. So I actually mentioned in one of the, I was told there are 3 Ds. One is do some whatever you have to do, delegate some, and dump some which is not needed at all. Because there's so much of work that comes, we have to organize ourselves. We have to differentiate what is that you have to do at your level, which is needed by nobody else can do, and you can do. And what is that you can delegate to others and still trust them and that they'll do for you. And what is that which nobody needs to do anything but just landing upon you? Just dump that. And yeah, I'm gonna say that's the reason why I want to stay in NHS because I think everywhere it is like that, whichever institute you work. Basically, it is a teamwork. Whatever you take, whichever aspect you take, everybody mentions about, oh, communication. Everybody mentions about rapport with colleagues and patients. Everybody mentions about interdisciplinary team relationship. Everybody mentions about medical ethics. Everybody mentions about etiquette. All these things, they come up only when you work and take up one thing as a team. It automatically comes. You don't have to separate them and differentiate them. It automatically comes. Respect to your colleagues because it's like a teamwork. And ultimate goal is doing something good for the patient.
Yeah.
Thanks, Venkat. I think one of the things that you said is exactly what Gayatri had also mentioned, but not in the same Ds. So same thing in, so that's a very good point that, consistency across systems. So thank you. Vidya, I think we should open it up for other
Subhashini
people.
has her hand up. Subhashini,
Yes.
you can unmute yourself.
Hi, everybody. Great session as usual. I just wanted to reiterate a couple of points which the others have made. I think one of the things that we are never taught, especially training in a government medical college or a major academic medical center, is financial management. Many of the former speakers have talked about how to negotiate, and one of my main gripes is that we women especially need to be a little more assertive when we start asking talking about money. First of all, we have that hesitation, am I going to be seen as somebody who's being very, aggressive? Whereas men is perceived as being, rightfully assertive. So one of the things I think we as female physicians need to learn is to know our worth and, ask for what we are worth. Number two is that we all work really hard to make money, but then how do we make our money work for us? So I actually did an MBA, a few years ago because I'm a glutton for constant punishment. So I keep, learning something new. So one of the things that was very useful to me was about to learn about how to invest my money. And yes, you can hire a financial planner for that. Many of us would say, why bother learning? But we all have to understand that financial planners' main interest is to make money for themselves. There was 1 year when the financial planner was making somewhere around 8% for me. Then I found that she was not doing a good job. Then I said, why don't I do this myself? It's not rocket science. So the next year, I made 15%. So I think we all need to make our money work for ourselves. And number three, I think this could be a session in itself. The whole self-care thing, I agree, with everybody that especially in this day and age where everybody wants instant gratification. Everybody wants you on the phone, everybody wants you on the pager. So it is very important that we don't feel selfish and we don't try to pour out of an empty cup, and we all develop some coping skills and also learn to reach for help, not just in terms of, let's say, medicine, also in other fields. Like when I wanted to start a practice, one of the first things I did besides my MBA was to join the local small business association. So if we start looking for, help, in other things like, how to manage a practice or how to manage the economics or how to manage accounting, there are always resources out there. There's a great website called Skillshare that you can join. It's nominal, and you can learn various skills. So those are the points I wanted to make. Thank you.
Sham, you have your hand up. You wanted to say something?
Yeah, I just wanted to echo what Puneet said, and then Suma also has this in a comment. Is now we talked a little bit about financial management on the practice side, but it's equally important to manage your own finances. And I think there's just too much stuff out there advertising about, people will take your money and double it in a couple of days. Anything which anyone who's selling you, that kind of ability is probably very suspect. And usually it only takes a little bit of work to actually read up a little bit about how the stock market works and how the bond market works, and how you can actually do your investments yourself in a reasonable way. And the goal is not to become the richest guy on earth. The goal is to just preserve your capital. And you don't even have to have a big money flow to actually build wealth. And this is sometimes crucially lost in the US, where people think that bringing a big paycheck means you're wealthy. That's not really in fact, some of the people who have the biggest paychecks are probably the poorest at the end of the day, because they end up spending everything and not conserving enough when you get old. But I agree that this is an important area, and probably it's a good topic for a session of its own.
Yeah, so we have done 2 sessions actually on financial planning, but yeah, we could revisit it. So Jimmy, if you're still on the call, you had something to say, please go ahead.
Hello.
Hi.
Hi. I mean, I don't know whether I am the right person to tell, because I don't consider myself particularly successful, but I have learned quite a few things after my medical school. Definitely during residency, I used to watch my seniors, the seniors who were very good at explaining things to patients. So I used to watch what they were doing, and then I tried to do the same and train myself. I think that's a very fantastic and interesting skill that you should do. Of course, communication skills. But what my concern is that the work environment of India has changed drastically in the last 10, 15 years. And that is one thing I think we need more focus on. If you look at Kerala, where I work, which is a very saturated place, if you look at a city, you don't have that luxury of asking for more money as for a fresher or even somebody who is out of super specialty 3-4 years experience. You are just most of the newer generation could be looking at working in teams and being taken as a salaried person. So how to negotiate this kind of thing, and how to negotiate the newer work environment where there's a lot of competition and your skills may not be worth that much. How to negotiate that will be really, really tough for the new generation. That's what I feel. Of course, this is not a lesson per se, but I think we need more thing on that. Of course.
Yeah, so one of the things Dr. G.D. Sharma, who's very active on learning general surgery, has said is move out of the saturated markets, like how the stock market, the financial guys look for emerging markets and invest money in India or somewhere else because the US market is not giving them money. Like that, move to a tier 2 or tier 3 city. It will not last forever, but somewhere where your skills are needed and will be appreciated.
That is true. That is true.
Everyone wants to stay in their own home and want the money to come to you. That's not going to happen to the next generation.
That is true, Vidya. One thing I strongly feel is that there are places where there is a concentration of doctors, like some of the cities in the south and other places. They are very much afraid to move to other places. So I would suggest that try working for 6 months in place where there is a need. Okay, in a junior capacity. That will take away the fear, and at least some of us will have that idea of moving to that place and filling that niche. There are places where doctors are needed, specialists are needed. That is definitely one thing. And another thing which I strongly felt, which was definitely brought out by everybody, was that we need to more doctors need to learn management and entrepreneurship. That is something which we cannot afford to lose sight of in the present scenario. We will. That's one thing I strongly feel. That's it. Thank you.
So we have Shivam Natarajan on the call. Shivam, would you like to add something to today's discussion?
Yeah, thanks. And I think everyone has given, just checking on things that was not emphasized enough. I think leadership skills. We are expected to become leaders. We are never trained to be leaders. We are, everyone thinks leadership is a born skill. No, it is completely trained. And I think we never emphasize, because at the end of the day, we all become some type of leader in wherever we go. And I think leadership skill is not taught enough. The other thing which was not emphasized enough is, although we talked about ethics, I'm just reflecting my days of learning. Maybe things have changed nowadays, but empathy, the ability to empathize with patients. Again, we expect it to be picked up. If you're working with a very empathetic teacher, say like Nalini or Smile or something like that, it sort of comes to you by imbibing. But it's never taught to be empathetic towards patients. And if you are very often we work in sort of technocratic, very intellectual environments and tend to be performance oriented, and we forget. I still remember OPD days of having 400, 500 patients in the surgery clinic and just calling them for 3 seconds or 5 seconds and remove your pants and examine them and then push them out. Maybe the circumstances were like that, but still I think the emphasis on empathy was never there as a training. The third thing which I thought someone will come up, but no one did, so I have to champion that, is adopting technology. Nowhere was I taught to even think of technology or adopt technology, but maybe nowadays the youngsters just do it from their mobile phone. But there is a systematic approach to train of how to use technology in life as a clinician, and that has to be taught. It has to come into the curriculum rather than just being taught informally. I feel some countries have started that, but I don't know about India whether that has happened. The last thing I want to say is, everyone talks about entrepreneurship, commercial, business, but no one has talked about innovation. We need to be innovators. We need to be taught to be innovative in our thinking, think out of the box and take risks. Traditionally, medicine is always taught as a subject where you don't take risk. I think unless we are taught to be innovators and taught to be risk takers, we take risk in our clinical job, like you anesthetists take too much risk often. No, I'm just joking. But what I'm saying is the risk appetite in medical field is not as much as it should be, is what I'm thinking of. We need to become more capable of thinking outside the box, thinking outside medicine rather than thinking inside medicine. Thank you.
Yeah, thanks, Shivam. We have Manohar Shah, again, a younger doctor who's very much active on social media, trying to help doctors do things other than just a practice of medicine or surgery. Manohar Shah, are you ready to speak?
Can I just interrupt for 1 second before he starts, before Manohar starts? So Shivam, thank you for your points. Actually, all of them that you made were made by the panelists. It's just that getting through every single point that was made we'd be here for many sessions. And that was the point of Ilangos, which is we need a second session. And, the mantle will be passed on to him to do the second session where all these things will be discussed in greater detail. But thank you for bringing them up. But they are very, very, very valid points. Manohar Shah, over to you.
Yes, ma'am. Hi, ma'am. Hi, everyone. Thank you for inviting me. Well, I'm surprised that I'm quietly surprised for many things. But I'm happy that there was another session on this important topic and which we talk about. The thing that surprises me is, especially in the course of my whole education, I have not seen any senior doctors like all of you from reputed institutes talk about this topic. And that really connects me with this community of marvelous medicine. And yes, coming to whatever the other doctors just spoke, Dr. Shivam sir has spoke about technology, innovation. Shubhashni ma'am has spoken about the financial literacy that doctors need to have. And I think Dr. Ajit has spoke about entrepreneurship, leadership skills, etc. What I understand is this, all of these things fall under spectrum of one skill that is called as emotional intelligence. We as doctors are getting trained just with IQ, but not with EQ. And the burden of being trained with that EQ is completely on us. So because someone asked a question someone has raised their point in the box that the previous generation was completely different to our generation, and which is very true. Like, I think to the amounts of stress levels that you as senior doctors have seen, I believe at some aspects is really multiple folds. But all of you have sailed through that. But unfortunately, younger generation, even for trivial stresses, they're taking drastic steps. When I used to think about what is this reason why the present generation doctors, see, some might disagree with me, and that's completely okay. This is just my viewpoint. I think our generation of doctors are becoming more sensitive and less sensible. Even for small things, they're using the word trauma, left and right. Even for petty things, they're calling, I'm stressed out. Exaggerating the stressors is one major thing that I see in our generation. That is one side of the coin. The other side is, yes, there are so many other stressors which your generation doctors may not be having, like the social media. Especially when a doctor is depressed or dull, if he uses social media, especially Instagram, God save him. Because the algorithm completely pushes those sort of content that you consume. You all know that. I think it is just the way of theory of the universe. Like whatever you think, you attract that. Same is with social media. And I think these are the certain things that we have to keep in mind as younger generation. And to me, I think burnout is a homeostasis problem. It's not just money management problem or time management problem or work-life balance problem. There are so many doctors with better work-life balance still burnt out, still lost their passion, still working like mechanical doctors. At the same time, I've seen some senior doctors who have very bad work-life balance, but still they're happy somehow. I don't know. Like their partners are quite happy with them. They hardly see them for a few minutes or hours a day, but still they're happy. So yes, work-life balance is essential. Yes, financial management is essential. All these things are essential, but when it boils down to one thing, burnout is simply when you're exhausted physically, mentally, emotionally, spiritually. And I think for physically, when someone is exhausted, we need to get back to our basics. I have underwent a health test like few months back, and my vitamin D is 11. And we knew that vitamin D, B12, B6, lack of that, simply physiological corrections sometimes can make us better to handle stress. And we have so many studies to prove that. So I'm fundamentally thinking now from physiology rather than just completely focusing on the psychology. Once the physiology, the physical health is taken, that once they have proper diet, proper sleep, which most of the doctors don't have. And lack of sleep can make doctors go nuts, insane. The cause of medical errors, medical legal litigations is just because of the sleep deprivation in doctors. It's a huge problem. I think we need to have a session on that, man, on sleep deprivation. So physical
Sure,
burnout.
Manohar. Before it was used as a badge of honor that I worked so many hours without sleep.
Yes, very
which
true.
may have been done much more harm than good. So Suma has been logged in early and she has her hand up. Suma, did you want to say something?
Yeah.
Yeah, I think I already wrote my points actually. I just wanted to say one thing. One thing that we were not taught, and I still think isn't taught adequately in Indian medical training, is being aware of your own limitations. Um, for instance, my field, MD pediatrics. A lot of people think that once you've done MD pediatrics, you're qualified to manage any disease, any problem in a child. And that actually isn't right. In fact, I think a lot of the, a lot of the dissatisfaction also that comes sometimes from patients is because, uh, people are stretching themselves. They are unnecessarily going, doing things that they really don't understand. And they should be asking for help, referring patients earlier. And that would make a lot of difference. And this insecurity that if you refer a patient, you've lost a patient is totally unnecessary. Totally unnecessary. Patients actually are grateful if you have referred somebody in time and they get the right care, the right diagnosis. Very grateful to the person who referred them. And this is unfortunately a very, very big problem even today. Even on LGS, I see people asking they put up some clinical scenario and they want to manage that patient, not realizing that they are not actually the right person to manage that patient. Um, so this is some, apart from that, most of my other points have already been made. The only other thing is bullying. Um, I think bullying is very common in medicine, and it's a trait that hasn't completely died down. I've faced bullies in my training, not only in India, in UK also. And but in UK, I learned formally how to manage bullies. I actually learned how to use the system, manage bullies, and emerge victorious at the end of it. And that is, the here what happens is either you have clout and you flatten out the bully, or you just quietly take the hit, keep on taking the hit, and suppress yourself and get a lot of long-term angst upon yourself. And this is a trait that we must change.
Suma, if I may interrupt you, have you been able to put any system in place in Amrita? You said NHS, you had a system by which you can overcome this problem. So in your own, in your institution or hospital or department or whatever, have you put any system in place for somebody?
In my department, I do not have jurisdiction beyond my department, but in my department, I will not allow any of my juniors to be bullied by anyone. And more importantly, I will not allow any of my staff to be bullied by anyone. If any of the staff are unnecessarily shouted at or this thing by anybody, I want them to come, report it to me. I'll take the matter forward, speak to the people concerned, and make sure we actually go down to the bottom of that so the people know they can't do it again. We've had incidents, and I have zero tolerance for this particular thing, to be honest.
Thank you, Suma. Dr. Mettu Pradeep Reddy, you have your hand up, sir. Would you like to say something?
Yes, madam. Good evening, everyone. Am I audible, madam?
Yes.
Yeah, I'm so grateful that I get to hear such seasoned people on a topic which seems to be covering a vast area of what medical schools do not seem to be emphasizing on once we are there. And I was happy to note that topics like financial management, dealing with bullies, dealing with professional competition has been taken up. But I thought one point of view somehow I felt could be talked a bit more was hello.
Yeah, please.
Yeah. So
please go ahead.
One point I felt which we could talk about was somehow most of us doctors, I could be stepping on some toes here, somehow we are not seem to be involved in much of the bigger part of the society. We seem to be quite a inward looking profession where we do talk about the patients, the stressors, the workload, uh, and of course other aspects which concern our profession. But I felt that if we could somehow manage to take a higher up view and get ourselves involved in a bigger part of the society build up or national build up or community build up, we could really take care of most of the issues that have been talked here, be it the right financial management, be it about dealing with burnouts, be it dealing with issues related to professional competition or stresses related to patients. Somehow, if we could, in some small way, manage to get ourselves involved in some of the community activities, it could really improve our emotional quotient, as someone managed to say that. That is of my small view. It could be anything. It could be a very small way of trying to look around the place where we are residing. It could be about maintaining parks. It could be dealing with people around us. It could be getting ourselves involved in some of the uh, neighborly activities. It could be simple tree planting. It could be dealing with medical camps. I somehow felt that if we could, in a small way, get ourselves involved in community activities which have got nothing to do with our profession, that would possibly make our medical school education a bit more expansive and a bit more with a broader outlook. So that's my 2 cents on what possibly the medical schools could have taught us, or even if they have taught us, we have not managed to get ourselves involved. So just getting involved for possibly once a week, once a month, or maybe once 1 hour in a week, that could make us much better individuals, much better professionals, and hopefully take care of most of the ills that our profession seems to be presently going through. Thank you very much for giving me that chance, Vidya madam. Truly grateful. And I was very happy to listen to so many of the experts on so many of these aspects of things which were not being taught in our medical school. Thank you so very much.
Thank you, Dr. Pradeep. Nalla, you have your hand up. You want to say something? Nalla Shiva?
He's still muted.
Yeah.
It's muted?
No, we can hear
Yeah,
you.
now we can hear you.
Yeah. Yeah. Okay. I just wanted to share the Middle East experience because a lot of you are from the West and most of you from the Asia. Middle East is a different perspective on medical field. Having graduated and studied in India and having practiced for 20 years in India, I moved here and 30 years here, I realized a lot of things. One, what we learned in medical school is patient safety. But what I came to learn when I came to Middle East was not patient safety, doctor safety. As an anesthetist, each of them look at only to be safe on their side, not on the patient side. That's one very important thing which I found it very difficult to understand because my teaching was completely different, and I've always been an anesthetist who goes out for everything. The next thing is, yeah, regarding the burnt out and work. You will be surprised. As a medical director, I had to sign for a local doctor who's an orthopedic surgeon who was 80 years old and he booked a case for a bilateral knee replacement. Now we were talking about no hours of work and ethics and what. So I didn't know whether this guy will be able to stand and finish the knee replacement. But then that's how work. That's what happens in the Middle East. And the third thing, financial, yeah, very important because there's a lot of money here as a doctor, you can make a lot of money in Middle East. There are guys coming from UK, US, India. There are a lot of doctors applying for jobs here. They don't understand the crust of what you can be in trouble. So I just wanted to pass a message that to come out of all these problems, I only realized one thing, and that's what Suma was telling, to build your own team. So I built my own team, and that is, we have a theater, as an Vidya knows, we have as an HOD, I made my own system, and for 20 years, what happens in my theater is in my theater. Like you say, what you get in Vegas goes out in Vegas. You don't take back anything out of Vegas. So that's a very important thing. So keep your team with you. But this burnt out and end of the day, the medical school medical school teaches you a lot of the right things, but you can land up in problems, and then to find your own solution and swim your way out. And in Middle East, I'm telling you again and again, it's not easy. So I went through all those challenges. I'm still happy. I'm quite proud that I'm from JIPMA. I learned all my basics, and I did my anesthesia under Vidya. So that keeps me going. But then not everybody gets that feel, and it's not possible here. So it's a good talk that
we
people
will
should.
have another session about healthcare in the Middle East and how doctors from India can
Oh
navigate the
yeah.
system. So we
Oh
will look
yeah,
on
I
to
would
you
love
and
to.
a
I
few of your
love to.
partners for that.
I can put in a lot of PPT then.
So we'd rather
Because
hear your stories.
there are so many
Yeah.
Vidyas, really there are so many doctors who are just pouring in here. They don't understand the difficulties that they can undergo here.
Yeah.
But there are challenges. But there are a lot of successful people who have made it millionaires.
Yes.
I'm quite happy. I'm happy here. I have no regrets at all, because I still kept the school of the Jupma school going on me, and then I kept my thing. It's not possible for everyone, but it's an opportunity that you should face it. You have to take it, and as everybody said, it's a challenge that all of us have to go ahead. And medical school will not teach that. Medical school will only teach you the basic skills, and you have taught me the basic skills. Yeah, I don't know how many cricothyrotomies for a difficult airway you might have done, but I've done at least 3 years in Dubai for 200, 300 kg patients. So that's something which nobody will do here. But still, you need that gut and that feeling. But that can be possible only if you have your own team, your own people, and that's where the team formation makes a
Yeah.
big difference.
Actually, in Marvelous Medicine,
Building.
we did a separate session on team building some time back. So hopefully we
Very
time to
important.
revisit, I think, after this. Puneet, you had your hand up. Did you want to say something?
Thank you, Vidya.
Yeah, I think most of the important stuff has already been covered. Specifically, the the management aspects and the financial. We sort of tell them it's almost a sin to think of money. I don't believe that we should be like the American. We have to auction like high class Mujaratis or auction ourselves like the film stars. I think it's still a noble profession, but I think we need to know how to charge. But the stuff that I think we didn't touch on is legal education. I think we need to know how to protect ourselves. I'm not sure about the martial arts bit, but at least legally, in India specifically, the documentation. I think in America it's very well taught, but in India, documentation, it's almost like, oh, am I going to write down or should I do it? So there's this stigmatization of the documentation, just like stigmatization of doing anything else in your life. Then finally, medical humanities and having fun itself. I think each part of the medical humanities, psychology, integrates a lot of these things automatically. Like, you look at the patient, you look at his social circumstance. Should I suggest a transplant to him? A lot of those things. And finally, having fun. I think they don't teach us definitely how to have fun. I thought you would want me to say that, so I did say that. I think lots of people mentioned about community involvement, and I'd like to share with you. Last week I spent in. I really suggest. We've got a lot of good centers in the south as well. In a center which is, 4 AIMS couples actually went to middle of Chhattisgarh 20 years plus back and set up hospitals. It's not just setting up a hospital in a tribal belt. It is how it's the reverse of what we talk about. We should get involved in community activities. It's how they have ensured, the WHO, the Almata Declaration, they have really proved how we need to get in our most backward. We're not looking at only at our 5% of the richest people, which all the corporates are vying for, but the huge hinterland which exists. And I really urge all of you to actually see, and we should do some special sessions on that, how they've done it. And there's absolutely no doubt that their work-life balance is better than ours. There's absolute the one of the main doctors who's there, his daughter's from SCMC Vellore. The son is in. So I don't think there's anything which is missing with those people. There's a fantastic center in Sitlingi, in Gudalur. This one was in Ganyari near Bilaspur. So I think we do need to look at those models as well. I think we should cover that in Marvelous Medicine sometime, Vidya.
Puneet, I just wanted to say that we all think that medicine makes us happy. I'm just putting that plug in. After all, medicine is marvelous, right? So, and talking about community involvement, Vidya, you should tell people what you're doing right now.
Yeah, so Dr. Reddy is also, who spoke earlier, is also part of that. Right now I'm in Bhopal volunteering for Mission Smile, where for 2 to 3 days, I try to do it twice a year. Hopefully in the future I'll be able to do it for more days. So from Thursday to Monday, I'm going to be here. We will be screening children for cleft lip and palate deformities, and then we'll be working sometimes 12 hours to get as many surgeries done as possible in as safe a way as possible. So people from all over the world and doctors from all over the country, we come together and then work together. So it's a great experience meeting other people. That's when people were talking about social engagement, something like this, when you go back, you feel charged for the next 1 month. You're very
the
happy.
Smile is with you as well. The smile is with you as well. And you are then in turn giving it to all of us. Absolutely, the ripple effect.
So also other thing that we did want to talk about, which Dawa Jangmu Sherpa has thing, is that not enough emphasis is made on research and research methodology and the importance of interpreting research. Actually, we had some 15 points lined up as part of this whole team, but we couldn't address all of them. So like we have already accepted, we are going to have part 2. So we'll postpone that. Smita, you have your hand up, and Shiv, you have your hand up too. One of you please unmute yourself first, and then the other one can follow. Smita, Bandil, and Shiv. Smita, are you still there? Okay. The hand is, Shiv, please go ahead.
Hi, Vidya. I actually joined a bit late. I didn't actually listen to the whole thing from the very beginning. I thought this was about the medical school. We're talking about MBBS, I think, but most of the things which were discussed are about, after post-graduation, like you've done your post-graduation, you want to set up your practice, you want to do this, you want to do that. I think what hasn't been discussed is what need to be introduced in the medical curriculum as an MBBS student. And those skills which you're talking about, setting up private practice, GP's setup, or, research, innovation, that comes much later. I mean, when we join the medical school, we're just kids. I mean, nobody knows what they're going to actually become or do as a postgraduate. It only later on we pick up what we want to do. But there are certain basic things which we aren't taught. I think JIPMER is a fantastic institute, but there is lots actually which could have been better, I think, if I were to go back there. I mean, I had just actually put in a message. There is undercurrent of bullying goes on quite a lot. The way I think, looking at my batchmates, some of them who are not doing very well, some of them went into additional batch. How they were treated was totally different. I don't think the teachers actually treated them the same way as we were treated, and communication is still not, I think, taught that well. I still see I was in Ganyari as well, just last week, and somebody just spoke about that center, and we did one of the courses was on acute critical care, and they were talking about communication in there, and how to communicate. They had a role play thing, and I asked them, okay, fine, you are talking about what need to be communicated. The family was getting angry, and those kind of things. And one simple thing was that whatever you are communicating to the patient, the same thing need to be communicated by other doctors as well. And they don't talk about among themselves. So there are different kind of communication skills also required. It's absolutely great listening to a lot of people, their experiences, but how this experience would be taught to MBBS student, that has not been discussed.
We addressed some of those things earlier on in the session, Shiv, and fortunately, as you must be aware now, the curriculum has been revised, and so now there is a ADCOM model in place, and the first batch of students should be coming out after the new curriculum was introduced, I think this year or next year, and hopefully in 5 years' time, we should be able to see some real impact on the ground. And as far as those of us who didn't get the opportunity in medical school, I think more and more of us are understanding, and we are attending many of these simulation sessions. And I also attended the ACC course that you mentioned when it was conducted in Chennai. And it was everything from communicating to teaching. There are so many skills that we need to acquire. And that was another thing that was emphasized by the panelists right from the beginning, is that, it's a lifelong learning process, and things are going to change all the time, and we have to be ready to adapt and adopt new things. Smita, if you're still on the call, please feel free to speak. I can see your hand up still.
Can you hear me now?
Yes, I can.
Oh, hi. Sorry, I was unable to unmute before. I needed to get a young person to get that sorted. so very, very sorry. So 25 years of living in UK and working in NHS, all the points that you said, hats off to you guys to have discussed all this. It was just amazing. One thing that I would say is India is such a big place, yet there is no option of flexible working, which I get in UK in NHS. I work 8.5 PA, that is 8.5% of what a full-time person works. So I can be a mother and I can be a very good doctor, and I get that work-life balance. And I think India being the world's biggest population and with so many doctors teeming there, why can't we create that environment so that people who want to, and that is so much good for mental health, especially being a mother, not feeling that I was not there for my children, but at the same time doing a very good quality. That's all that I need to add. Something that India needs to consider and embrace towards. Thank you very much.
Yeah, thank you. Thank you for your inputs. I mean, we are really, really way out of time. So if anyone really wants to say something, please put your hand up. Otherwise, over to you, Radhakrishna. It was strange how the morning, normally what Radhakrishna writes in its morning introduction will sometimes have nothing to do with what I had in mind when I planned the topic.
Maybe Patta is burnt out. Patta is burnt out.
No. Or it will be a completely different twist to that.
Telling working hours. I don't know how many hours Patta is working or you're working. Somebody in UK is telling 8.5.
But for once, so Nala, but for once we were like, as if we had actually talked. His whole write-up was exactly what the 7 of us or 8 of us had got together and decided to talk about. So this is something that has really brought the audience, the panelists, and everyone involved together. So over to you, Radhakrishna.
Yeah,
Nalasam, I work very little. Vidya knows that, and I'm chilling out more than Venkat knows,
So
Ravi
you
knows.
make more money working less. I didn't know. Can you
Money,
teach
well, I'll
me
talk
that
about it.
also?
Yeah. Now, see, I
He's
think
working
much.
on other things. I mean, not
Yeah.
surgery. He's not
Yeah.
doing nothing. He's doing other stuff. That's all.
Yeah, much water has flown under the bridge, and as I resonate what Shivakumar Singh said, that very little of it is what exactly what we should be taught. In everybody poured their experience, everybody poured their bucket of woes and stuff like that. Of course, these are all don't exactly come what under the heading what should be taught in medical school. I'll tell you a couple of things, which will sort of summarize what most people said. As first of all, in India, 30% the medical service the government sector and 70% private sector. JIPMA prepares us for the government sector, it doesn't prepare us for private sector. All JIPMerites do well in IAIMS or Chandigarh or in some government institution or NHS or in the US. But, very, very few JIPMerites do well in the private sector in India. I should point that out. And when I joined into the private sector, I mean, I'm very hesitant to handle money because, Venkat Kodamati says, how can we talk about money to patients or handle money in a clinic? Even now I don't do. Vidya also doesn't do. Vidya is very poor in her economic things. She doesn't know how to bargain with the management and, she remains the same. I think all JIPMerites are that. That one aspect somebody has to teach us. Second thing is we are all taught ethics. I think we have to be taught a little bit unethics also. We should know how to pay kickbacks and we should know how to get kickbacks from radiology and this and that. We don't do it and we lose a lot in that bargain. We don't pay any kickbacks.
We gain a lot of sleep in the
Let me finish
bargain.
with my time now. We don't pay kickbacks to referral doctors and we don't get referrals, because we think that's very, very unethical. I think that bit has been. We should be taught a little bit of crookery because all our hospital owners are crooks of the highest order. They make money out of us. They undervalue us. They utilize, I was talking about work ethic yesterday to Vidya in and the theater and see, she's definitely not paid the amount for which she's worked. She continued to work. She enjoys her work, but she's sincere, and that's where this part is not taught to us at all. Another important thing we are not taught is how to be united. We doctors are not united. If me and Vidya are united, we'll fight for the same salary or whatever. We don't. She gets us, then I get mine, and somebody gets. Then another important thing is, see, barbers in India have a basic minimum. You go to any barber shop, shaving this much, haircut this much. They have a minimum thing. We don't have any minimum. We don't do that. We are ready for anything. And most importantly, the ones who suffer the most are the junior doctors. In the private sector, junior doctors are treated like dirt. They are undervalued. They are not given proper care. They are not given proper salary. And this is an area which is a huge area where, our young people get very discouraged. This also, we have to be taught unity in our medical schools. And more importantly, we have Sham coming to JIPMER talking about AI or Shiv Shankar Singh talking about nerve blocks and when Kotamati talking about after. These people should come back and talk at these things in JIPMER. They shouldn't talk about all their subject matter that we know everywhere. You talk about how to be good private practitioners. Sham should come and talk about how to get your money in the right way. I think these things have to be taught in medical school rather than what we all discussed before. Because I think these slowly have to get into the curriculum and our younger generation should benefit from our experience or the lack of Vidya.
So, since we are really out of time, let's, Ravi, would you want to get back to the panelists for their last comments or whatever?
Sure. Let's just go in order. Anjali, in summary, one message to the trainees.
Yes, sir.
I completely agree with the points which have been highlighted by the Patta Radhakrishnan. My first sentence would be that there should be a good, what you can say, a correlation between anatomy, physiology, or a first year to third year. If somebody is teaching us appendix, now why we are learning appendix and how to surgically intervene the appendix and what are the possibilities, in such way it should be highlighted. Second is we should have a correlation between
Sorry, was there a freeze?
Yeah, I think her networks,
right.
so we'll wait for her to get back. Meanwhile, maybe you can move on to the next person.
Let's
Anjali,
move
please
on.
sort out your network issue.
Yeah, and Gayatri, you've been very eloquent. What is it that you would like to tell other trainees, and what is it that you'd like to tell us, the older generation?
I think in addition to the points that I mentioned, some of the points that really resonated with me from the discussion, I think that's what I would want to leave as my departing remarks, especially to other people of, maybe the younger professionals who are listening. One, that Dr. Ilango's statement of constantly unlearning and relearning. I think that's one thing that we're not taught in medical school. I agree. We are taught that, whatever we were taught is gospel truth, and that's what we have to carry on and learn for the exam and continue. But that's not how it works. And I understand what he said is absolutely true. There's enough evidence for every argument if you search for it. And, there's for and against, there's enough literature, there's evidence either way. So I think that's a very important part of real world practice, that, you have to constantly be adaptable, open to changing ideas. So that's one thing that I really take away from this, and I think that's really true. The other one thing that I really appreciated was, I think Dr. Shivan talked about how we are not taught to innovate. We're not taught to think. I mean, especially surgery, you learn from how your seniors do the procedure. You learn from how your professors do the procedure, and you're told to systematically copy and mimic. That's the best way to do it, and you're encouraged not to do it in a different way. But I think that resonates in most other fields, right from medical school. So I think that is a very important takeaway message from this session, and I think that's important. And as far as the seniors in the audience, one thing, since it was a hot topic, was about this issue of burnout. And I've heard it being told, oh, I think this generation lacks grit. That's why they complain so much. We got through it. Why can't they? I think the challenges are different. I think I forgot. I didn't catch his full name. Dr. MH was his name on his.
Manoharsha is more your age than ours.
Yeah.
None of us said that. So I want disclaimer. None of us said anything about younger generation.
Yeah,
very
but
politically correct.
I think some things that he said is true. I think the challenges faced by the present generation is different. The competition is sky high. I mean, kids, they come into medical school thinking about how to prepare for NEET 5 years later, not how to get through MBBS, because there are only so many seats, and then seats and fees and, social media pressures and exposure to litigation. All these stresses are maybe much more relevant than it was maybe 15, 20 years ago. So it's a different era. So challenges are there. So maybe, it's also a different perception. Things that were taught to be, just swallowed and put up with, now people don't want to put up with, and they're vocal about it. So you can argue that it's more sensitive, but maybe they're more aware of themselves and their needs. So knowing that, approaches differ, and maybe, that's how we should look at it. So that's why maybe it seems to be more, because it's reported more and it's recognized more, and not just dealt with
as part of life that it was before. Yeah. So
Thank you,
that's it.
Gayatri. I think that's a point very
Thank
well
you.
made. We've all learned that point from our children. If nothing else, that we have to take all these points into account. I also want to reiterate something that Dr. Sridhar once said, who's a very senior member of Learning General Surgery. He said that 80% of what he uses in his practice today is something that he learned. It's not something that he was taught. So, there's this whole concept of constantly learning more and forgetting is very, very, very important. Vet, any concluding thoughts?
Yeah, I think I'll completely agree with RK when he said most of the discussion has been what we can learn after doing MBBS, and I stick to my point saying that look at that young age, most of what we've discussed cannot be taught in the undergraduate curriculum. It cannot be curriculized, if that's a word at all. But I think soon after MBBS, in the first few years itself, somewhere these experiences have to be built in so that we learn what we've learned after taking so long. That learning should happen in much shorter duration so that you're much better prepared. An example could be the management techniques and communication. Somewhere along the line, just soon after this, we should be sensitized to get exposed to. That's all I think. Because as RK said, we've come into the private sector where we are totally at bay, and took so many years for us to really get used to it. And I also till now I don't collect the fees directly from my patients. It's done paid at the reception counter. I don't feel comfortable even now.
Fair point. So Suren, and apologies before everything else. We've kept you up for so long, and it's so late where you are. So apologies. Any concluding thoughts?
Coming back to Wall Street, Gordon Gekko, he reckons greed is good. But again, you got to decide how much, and there is an ethical component to it as well.
Beautifully said. Perfect. Yes, I think he also said that when other people are fearful, you should be greedy. When others are greedy, you should be fearful. So, but that might work for Wall Street. But sorry, Shyam, any concluding thoughts? And please be warned, you're probably going to be pulled into the next version where we talk more about research.
Yeah. I don't know, it's a hard balance to achieve, that you want to learn all these things. Now, even just learning the knowledge of medicine, it's probably one of the longest training periods for any career, right? So to become a neurosurgeon, you're probably like 35 by the time you're done, or 30 by the time you're done. And that's just the skill of clinical medicine alone. And now you want to layer on top of that all these other things, then essentially you're going to be in training half your life. So somehow we have to cut out, my guess is, some of this knowledge part of clinical training. And maybe we don't need to learn that much knowledge. Maybe AI will come and help in areas that AI can do better than humans, and then humans take over the rest of it, especially in the EQ space. So it's good to lay out all these huge number of topics, but practically speaking, you can't squeeze them all into a very short period of training.
Ravi, your camera's off?
Yeah, sorry.
Yeah.
I am getting called.
Yeah, so meanwhile, I'll ask Santosh to give his closing comment. Santosh.
Thank you, Vidya.
Yeah, thank you, ma'am. Now, I think that most of the topic has been told, and there are so many experts and there are so many seniors that who have worked above my age, actually. We came to learn about from those things. So we'll be taking those matters and we'll be learning, because we are getting some knowledge experiences from the old ones, and we'll be doing some innovation from our side. That will I think that will give a good idea to go ahead, I think.
Thank you, Santosh. Ravi, you're ready? Otherwise, Venkat, your closing comments.
Yeah, no, just what I wanted to say was there are several concepts and skills that were underemphasized or even underaddressed, and we learned independently and we imbibed them. Now, after we finished, after so many years, new terminologies have come up: emotional intelligence, resilience and coping mechanisms, healthcare systems and policies, right? And conflict resolution, holistic approach to the patient. These are all hidden. They're just new terms that have come up. We have actually seen our consultants, actually, they did practice these things and we imbibed them without them teaching us. But what I say is that these are to be actually, now they are actually given proper terms. So that's fine. That's good, in fact, so that the junior doctors are coming up now and the undergraduates, they learn these things, and there's a uniformity now. And other thing is, there are certain things which are like imbibed or have to be these things. But there are certain things which have to be hammered in, like I don't know whether nobody brought up this CPR. We never had anything like that, certification or recertification of CPR, and other than like quality improvement or audits or anything. We never had anything concepts about this, but these are some important things. They have to be hammered to the undergraduates. Everybody has to be involved in that, and it has to be when it's an enhanced something, retention, and all have to be done. Not that somebody can imbibe and somebody can't. It has to be done for everyone 100%. And these are the things actually which works as when they do a CPR or training, or when they do audits, it's like a teamwork. And there they learn the communication skills. There they learn how to deal with, with the colleagues and rapport with the colleagues, building up with them, and the interdisciplinary relationships. All these will come up. So there are certain things which can they imbibe now, but they have given now various terminologies and like medical ethics and etiquettes, all these things. So there are things, but there are other things that have to be hammered in, and for that, like either a rather than, and if you remember, we never had. Now there are PowerPoint slides. The first person when we were undergraduates was Narasimhan, who used to project slides for us in pathology, if you remember. But he used to do it at the wrong time at 2 o'clock lunch, and everybody used to switch off the lights and everybody used to go to sleep. But he was the first one. So the methods of teaching have changed as well. Now we have PowerPoint slides, we have role plays, and all these things. So they are really in the sense that everybody's involved in this, and there's enhanced retention now. So that's the difference.
Yeah.
On behalf of Marvelous Medicine, let's cheer up India for India-Pakistan match that's going to be on 23rd. Yeah, cheers up. We got to have some fun also. Yeah.
Yeah. Truly,
Yeah.
Ravi, your closing comments, because
anyway, India beat Bangladesh today.
Yeah, that's why he's saying next match. He's getting ready for the next match.
Yeah.
And that's in Dubai. And I'm going to be in the stadium, guys. I'll send you all the pictures.
Yeah. We'll vicariously get the pleasure. Ravi, your closing comments.
So yeah, all I wanted to say is that this is a really vast topic, and as people have reiterated, some probably should be curriculized, using Vet's word, but there are others that we have to learn on our own. A lot of things may not be relevant to everybody. So for example, somebody who wants to work as a pathologist doesn't need to know about practice management or even so much about communication. So there's some individualizations that need to happen as well. So I like Vet's idea that this is probably, if this has to be part of a curriculum, it has to be after an MBBS course or a basic medicine course, which is for everybody. And then each individual specialty can have its own set of courses that go beyond medicine. So but I also want to reiterate to everybody that none of this is difficult. Everybody can do it. And the newer generation particularly is way smarter than we are, or at least they keep telling us. At least my daughter keeps telling me that. So if that is true, then you guys can do anything you want. So there's nothing to be afraid of, and everything to be very incredibly enthusiastic about. So thank you.
So thank you, everyone. Special thanks to Suren for missing a whole night of sleep. Thanks, Venkat and Shyam, for taking time out from your vacation time.
Ma'am, Anjali here.
Yeah.
So suddenly there was a disconnect. Okay. Can I?
Go ahead.
So my closing comment was actually it was not actually made aware about what is the correlation between the first year and third year, why we are learning anatomy, and if that anatomy would be taught by a surgeon, it will definitely add a grace to the anatomy. So no correlation existence was made between an internship to the PG curriculum and to the best clinical doctor. And what is the end point of becoming a good or successful clinician was not defined, because that has no end. So no cross questioning was the only norm. Teacher what has been told, like Dr. Patta said, we have to be in the ethical boundaries, this and this should be followed. So these are certain things which we need to change as we are doctors of the non-technical era. So at the end, I will like to summarize that instead of becoming the doctors from the movie like Munna Bhai MBBS, we should be more trained in the empathetic way. There is a famous dialogue from from Rajesh Khanna from the movie Anand, that Bamushai, zindagi badi honi chahiye, lambi nahi. But here in the medical curriculum, it is exactly opposite. Zindagi badi honi chahiye so that you become a good doctor. Thank you very much.
Thank you, Anjali. Thank you, Anjali, for the closing comments and for taking so much time off despite your busy practice. I'm sure you have to get ready for tomorrow. Thank you, Santosh, Bet, and of course Ravi. I think he had probably factored another half an hour from his work day, but since we have exceeded by an hour, so I think he had to log off. So thank you all on his behalf as well. We'll meet again next week with an episode of Beyond Medicine, which is going to be about a project on temple conservation. So we already did a session on temple architecture. So this is a follow-up by, the talk will be by a professor from IIT Madras, and we'll have a plastic surgeon who will be the moderator. So we'll meet you next week. Till then, take care and stay safe. And sorry for the very, very long session.